Losing my touch. All right. This is where we're going to start. This is basically the anatomy of the joints and how they work and how we classify them. That's important. Then we're going to look at the joints themselves. Uh, Basically, they have about a half dozen joints that are unique in that way rather than being more generic. And that's how we'll approach this. So effectively, it's all about planes. We go back to that basic construct of the anatomical position. So is it moving in the sagittal plane? That's typically flexion and extension. Is it moving in the frontal plane, which you're going to learn is either abduction, moving it away from the midline, or adduction, moving it closer? Or is it rotation, where we're moving it in transverse plane? So when we look at those motions and we add them together, we're able to, is it one axis? Okay, in other words, is it just moving in one particular plane? Is it more than one? Is it two, or is it three? Or is it basically doesn't really move in any plane, it just sort of shifts and slides? And that's really what you're going to see. So we have non-axial, uniaxial, biaxial, and multi-axial. So one, two, and effectively all three. And so gliding, just this little shifting. And remember, in the wrist and in the ankle, those tiny joints, all those neat little bones, just kind of shifting and moving just a little bit around. That's gliding or sliding. Angular, just that. Typically, flexion and extension would be good examples. Rotation, you can use either medial or classic anatomy. We talk about medial rotation versus lateral rotation. Internal and external work just fine. And you'll find it in, if you're in a hospital, they'll basically use the orthopedics will typically use, and physiotherapy will use internal and external rotation. And anatomists will talk about medial and lateral rotation. To me, if you put, if it's internal and it should have been medial, it's right as far as I'm concerned. I'm not going to go crazy over that. So flat bone surfaces glide or slips over. Intercarpal, intertarsal, and those superior and inferior articular facets that just shift a little bit, that allow this accumulation of all those multiple joints movement. It's always good news and bad news. The good news is you have a lot of little joints, okay, moving a little bit and producing, let's say, relatively speaking, a more substantial amount of motion. The good news. What's the bad news that you ask? The bad news is you have so many joints. When someone gets arthritis or is injured, there's a lot of joints that can become affected by it. So, I mean, there's nothing, there's upside and downsides in the living systems for anything. Some things help, some things hurt. So, it's the old story. Excesses are just as problematic as having insufficiencies that are there. The dichotomy. So, so here we are, sliding and gliding, classic areas, wrist and ankle, like that. And this accumulation of movement is really, so that's the classic gliding or sliding joints. That's actually one type of joint, as you will see shortly. Angular, flexion and extension. Okay, by definition, if you increase or decrease the angle, if I'm increasing the angle, let's say I'm extending it. If I'm decreasing, I'm flexing it. And if it goes past an area of the anatomical position, so this would be a hyperextended elbow. You have a little space. Remember I talked about that in lab, because it's bone against bone. When you hyperextend it, something's going to give. Same thing with the knee. You reach a certain point where it's anatomically impossible. Either something is going to break, fracture, or you're going to end up with soft tissue that's going to stretch irregularly, and that's going to cause problems. See, there are a lot. Roethlisberger had a lot of trouble periodically, because the guys would be tackling him, maybe throwing him off, and still able to get him not this. He'd end up with hyperextensions all the time. So, and you'll see this in a lot of areas. They have some illustrations you'll see here. So your neck it's certainly designed to hyperextend to a certain amount. That's there. It's just the nature of what we do with it. The muscles are so strong up there. There's a large amount of range of motion that's associated with it. So sometimes you have hyperextension. Your back's the same way. Hyperextension is sort of built into it, as you can see here. I mean, and again, there they're showing you a little bit. Yeah, and we don't associate so much with these kind of, it is one plane movement extension. I don't know if I'd call that flexion, but you can make the case. But certainly, as you can see, there's a point of no return when you get anatomically past how far it can go in the other direction. It's either going to hit a bony stop or soft tissue wise. Next thing you're going to end up with some kind of dislocation. When you're in the tree, think of those as sagittal plane motions. When you're in the frontal plane motion, again, and we always say abduction and adduction. Add and abduction, you do that a lot. Depending on if you're going to work in a medical environment, a clinical environment, you really want to be careful because we're going to talk about afferent and efferent. And I always say efferent and afferent, because you're saying literally afferent and efferent. It's not that easy. So adduction and abduction. So we do a little bit of spelling or letter emphasis. So again, moving from the frontal plane away from the midline. So I'm abducting, or I'm taking my feet, my legs, I'm abducting, the anatomical position. At the same token, I'm adducting. I'm going to take them from here and I'm bringing them back. I can even hyperadduct, adduct. When you look at foot position, normally anatomical position is like this. So it's not so much legs, but wide. The feet actually, it's almost like you're out tight. And when you're and if you adduct it, you're more like pigeon toe. Just fine. Some of the feet have funny, the names are used differently. They're there. And see, circumduction involves all of those. It involves flexion, extension, abduction, adduction, and rotation. Circumduction is the movement that defines your two ball and socket joints. You don't have two of them, your shoulder and your hip. And again, that means that you can effectively stabilize this, take a pinky or a toe, or an index finger or a big toe, and trace a circle. So it'll be effectively, it looks common. These illustrations. So we call that circumducting. Here we are. She's circumducting. So rotation is just that, around this long axis, either medially or typically internally or laterally, externally. And there's a variety of things where this occurs. We'll see that in a variety of things. Certainly femur and humerus do this, but there's other areas, as you can see, do this. I mean, clearly this is rotational in nature. It always drove me crazy. My daughter, I don't know if maybe you guys do this. I get her up in the morning, and it was like she went to the chiropractor herself, and she went with a loud click. Have you ever seen anybody do that? Oh my God. I thought, I mean, she would do, first thing, it's like, oh my God. I mean, the next thing I hear, she'd be spinning around. To like from The Exorcist, spinning up green stuff. Movie from a long time ago. Exorcist. It's absolute truth. Specialized motions. Okay. Radius and ulna. Yeah. Because that's the rotation. There's a joint that you will see pivots there. There's only two joints that pivot. The atlas and the axis. And that head of the radius and that radial notch on the ulna that are able to you hold it at 90, and so I'm not allowing my elbow to move per se. Just radius and ulna. So pronating, palm down, supinating, palm up. You see somebody's in a prone position, they're on their belly. Supine position, they're on their back. Foot-wise, we use that if you kind of force your foot to flatten out, it's pronating. If somebody looks like a flat foot or a foot that's rolled in, pronating, they're kind of like the edge of the feet. Supinating. A little bit different. And the other one with feet, years ago, if you used to call this flexion, when you bring your toes towards your nose, and extension, you're stepping on the gas. It was a little confusing, so they created what they call dorsiflexion, bringing it up. Plantar flexion, pushing it down. Okay. So bending foot toward the shin, not so much pointing the toes as Yeah, I think stepping on the gas. Okay? And then I just show you some illustrations, waving your feet at you. And this is what happens. You're going to hear when we talk about mechanically, when we look at joints, the most common kind of sprain is an inversion sprain. That's when you're walking along and you catch something, you twist it, and you're up on the outside of your foot. You invert it so the sole or plantar aspect is pointing toward the middle. That's what that is. So the sole of the foot faces medially. Eversion sprains are worse because they're not anatomically. That's the kind of one where you're more likely to fracture. So when foot's planted and they get tackled that way, where they're in any type of a sporting event or you just catch it that way, roll toward that. And the sole facing laterally is a natural plantar aspect like that. And again, jaw is strictly protraction, retraction, sticking it out, pulling it back in, moving it side to side. Those are the unique things that your jaw is able to do because of, you're going to see an articular disc, a little a la a knee meniscus, an articular cartilage disc that's sitting in there. That gives it, when you put those discs in, good news, it can do more things, move more freely in a number of directions. Bad news, if they get damaged or not there, and then you get things like TMJ. You get things like torn menisci in a knee. So like more things to go wrong. The more complex the structure is, the more things that can go wrong. The knee is the most complicated joint. Before the advent arthroscopic surgery, it was the most dreaded injury for an athlete. It was like, I could just, they used to, on Monday Night Football, oh, please don't let it be a knee. It ended so many careers for shortened. And that was, it was always, people just didn't come back. And now today, obviously, that's just changed a lot with the degree of technology. Same thing with like Tommy John surgery. Here's protraction, retraction, elevating and depressing, opening, closing your mouth, opposing your thumb. Really, they needed that illustration? I can show you one about extending a finger for that. See, I got a smile. Got another smile. The back's usually pretty receptive. We got to work on this side of the room. You're just not as good as you used to. 6 different types of joints. Okay, plane, those flat ones. So that, again, you're going to see those in the carpal and tarsal areas predominantly. So flat surfaces, this we call non-axial, just shifting, sliding in different ways, classically there. The true hinge, there aren't a lot. Okay, they only allow one. And that's why I made the point when we were in the lab that the true hinge, really, the elbow is probably of the joints that we refer to most frequently, is most commonly that because of this trochlear surface. Again, it's like a pulley that you might, did you do pulleys in physics like Dr. Buxton? Yeah, that kind of it. And you have the sort of the reverse side of it because you have that ridge in the middle. It doesn't allow that side to side wobble. So it's very much like that. The other ones that are quite a bit like that are your interphalangeal joints. Not here, not metacarpal phalangeal or metatarsophalangeal. They are a little different shape, as you will see, but the interphalangeal joints, either there, here you just have one interphalangeal joint, either proximal or distal. Here these are called proximal, and these are distal interphalangeal joints. Between the proximal phalanx and the middle is proximal, middle and distal is distal. And so those are much more like true hinges. There's not a lot of wobble if you were wiggle room in those. These are only 2 of these pivoting joints. They're by definition uniaxial, the head of the radius, as it basically articulates with that notch on the ulna called the radial notch. Again, anatomically we name things not for the bone that they're on, although we do sometimes, often for the bone that's going to articulate. So the radial head is received by the radial notch. Although the radial styloid and the ulnar styloid are projections on those bones named respectively. It's confusing, I know. If I hadn't been studying this and teaching it for 50 years, I wouldn't remember it that easily. And here, you can see, and the other one is C1 and C2. They didn't show it to you here, but they should. That atlantoaxial joint, where you have and you're going to have to know those bones for the practical on Monday. You have to identify the axis and the atlas. You could call them that. You can call them C1 and C2. The odontoid process, the fact it's the only pivoting joint. All those are things that, that will help you. So here you can see it again. Now, a lot of our joints that move a lot, metatarsophalangeal joints, metacarpophalangeal joints here. So with most of our fingers, we can do those kinds of things. We basically can move it. You can flex it and extend it, but we also can move it. Yes, Jenna.
So for Monday, we need to know all the joints.
No.
So we don't need this stuff.
I don't. My inclination is, let's say, no joints for this. Normally, here's what I would even show you. When we do the knee, I would have you identify the parts of the knee. I have enough stuff with the bones. Okay? No one's objecting. Roommate's sick.
Then on Monday, she asked me if you said anything to me on Monday about her missing class. And I said no. And you just said it now. So that's fine.
But she wrote me. But she emailed me. That's fine. Unlike a lot of the newbies in the class, she's definitely paying attention. They're freshmen, they're clueless. So, how do you spell that? It's on the PowerPoint, it's in the notes, spell it. Do I look like a dictionary walking? I hate that. Could you repeat that? Yes, I could, but I'm not going to. I mean, one of the you can see one of the words. She goes, "Can I eat this in here?" I said, "Can" suggests the ability. May is asking for permission. You may, you can, I assume, but you may certainly. That's right. I love correcting grammar. My wife and I correct each other's grammar. I got to start doing it. When you're trying to teach a Yinzer grammar, it's not easy. She's a Yinzer. Pictures on the wall. Her inner Yinzer. These are called condylar joints. So think of something that by creating that roundness, interestingly enough, the tibia and the fibula, because of the menisci, create a condylar joint. So it's not just flexion and extension, but also a certain amount of rotation is permitted. That's the beauty. So it's biaxial motion. So sometimes it's adduction and abduction, and sometimes it's more rotation, like in your fingers, flexion, extension, and a little bit of rotation. Okay. In the knee, okay, I beg your pardon, flexion and extension and a little bit of adduction and abduction. In the knee, it's rotation. And I mentioned to you before, when you at heel strike, when you begin to bear weight, that knee flexes just a little bit early when you're walking and running, enough so the transmission of the body force. You're striking the heel at 3 or 4 times your body weight. So if you did that stiff-legged, so to speak, I mean, your back and your hips are going to have something to say about it. And this is there's only one of these, saddle joint. It's only in one location. That's the base of the first metacarpal, and that's the trapezius. What's really important about the trapezius bone, when it's why thumb fractures and fractures that go into that first metacarpal trapezial joint, because that's how you oppose your thumb. it looks for all the world, basically like you're almost you're not. You're not quite creating circumduction. So you have enough motion, depending on the plane, it's either AD or abduction and a certain degree of rotation, but not complete enough to classify it that way. So it's really unusual. So you have a saddle on one side and the reverse of the saddle on the other. That's what they define. It's the only place in the body. So it's unique, and it's why when you break the darn bone, it's oh man, you're looking at that going, oh, the rehabbing this is going to be a problem. You see a lot of wrist fractures in elderly people because they have a tendency to fall. It's like I was talking about the college fracture. A lot of times, they'll fall depending on the angle. They won't catch themselves. You get this. We used to have so many. I mean, it was just. I told you we had an ortho clinic. I mean, we easily had on a Wednesday morning we'd have 100 people. We probably, 4 of us were attending, and one attending physician, 4 residents. We're slapping on casts. We're giving injections. We're scheduling people. You're running around like a chicken for 4 hours. Lots of fun. And you learn a lot with that, but you're just doing so much. We had the contract in Philadelphia. It was called P&F, Police and Firemen's Clinic. So one afternoon a week, we would go with one of these doctors, and all the policemen and all the firemen, their medical plan, they had a clinic, a healthcare center for them. And you can imagine between the policemen and firemen, all the kind of injuries, plus their children, plus their family. Just fascinating. And we had another program where, because the hospital I was at, this is all as an aside, in Philadelphia, very well connected South Philly Hospital. It was in North Philly, very, very well connected politically. The mayor was Italian American. He came to our hospital. That was like we were his private hospital back in the old days. Interestingly, normally you have documentation in a hospital where the patient has a chart and you know who's in the room. We had some guys come there who we didn't have charts for. Only limited people were able to tell them. And they had very sturdy guys outside that obviously were packing. Okay. They were connected in a familial sense. I mean, we took care of a lot of people who might have said we had ties to organized crime, to be polite. So, nevertheless, the point of the story was eventually we got the city prison contract, and they built an extension on the 2nd floor, a prison bar lock unit. So you had basically you entered gated, iron gates outside, and then in that unit. And we would have prisoners coming outpatient, and after they were got out of jail, you'd have the med area. Then you'd have another bar unit for where they were inpatients for long periods of time. Oh, wow. We had some fun. So we had Women's House of Detention, House of Corrections, House of Detention, Holmesburg State Penitentiary. We had to watch out when the prisoners were having, a softball game. Got pretty, because that's not what was happening. There was something going on, riot. So much trauma, just oodles of stuff. Here's the only 2 ball and socket joints by classification multi-axial. Obviously, a greater amount of rotation, a greater amount of freedom, so to speak, in this. And this is what happens joint-wise. And we'll look at this a little bit in lab. And what Jenna and everybody, what we'll probably do is after the bones thing, we'll take a look at some of the joints more specifically, since the bones will be out, and just to understand, like here, you'll see that obviously it's got a lot of bony overhang superior, and as you'll see down, if you go in and look at the skeleton, posterior. So when they dislocate, they dislocate anterior and inferior. They come out and down. They come out forwards and down. The anatomy that surrounds it tells you all of these things. It's very, very interesting. Thank you very much. That's done with that one. Adios. Have fun. But that's where I'm trying to give you that. I mean, you'd have to be every doctor who was a resident and they worked emergency room or they worked in a city hospital, they're all going to have these same. My stories are not unique. They're unique to me, but they're not unique. Everybody, we all have crazy war stories like that. So when you see that, whoever was doing the medical advisement for Noah Wiley and the pit that they're now filming again over at AGH, they live that. You know, they've had the clever thing is they're doing it all in a day to show you how it changes hour by hour. But that was the order of the day. Typically, it was traditional medicine to prepare you for having to focus, being able to be your best when you're dog tired. It was typically 30, and they can't do it anymore. You have to be out for 36 straight hours. You're just going to make mistakes. The only stretch I ever did of going in, even though I wasn't staying in the hospital, was 23 days. You're a freaking zombie. Even though you're going home and sleeping, you're a zombie. It didn't happen. I was assisted by the fact that my first wife, for most of that time, was the head nurse in the emergency room. So when there was something good, she made sure I got called in. I'm trying to sleep. I know you're being helpful, but don't do it. So here we are. These are selected synovial joints, and the uniqueness of them, as I said, uniqueness is good, but uniqueness is bad. So the jaw, it's a hinge, opens and closes. So if you want to call that flexion and extension, go ahead. We just call it elevation and depression. The nature of that joint between the mandibular condyle and the mandibular fossa on the temporal bone is very, very significant. Okay, and it really only has one really strong structure along the side called the lateral. So it's really one big thick ligament. What holds bones together are ligaments. Okay? And so the architecture of the bone, the ligaments themselves. So this is called the lateral ligament. It's on the exterior of the temporal mandibular joint. That's the big player. Other than that, it's just the anatomy. The problem is, it's a hinge for depression and elevation, and it moves side to side, so it's a lot more elaborate than that. So you can move forward and backward. The most easily dislocated joint in the body, not your shoulder, and the acromioclavicular joint is an oddball. It really doesn't classify as a class. It's really not a synovial joint, so it's probably not in this discussion. Again, it's more of a gliding and sliding. So when you hear about a shoulder separation, it's those two bones, scapula and the clavicle, where they come together, what they call the acromioclavicular. It's the acromion process of the scapula and the clavicle. Basically, they come together, and when you fall and brace yourself, sometimes the clavicle, most frequently fractured bone, fractures. Sometimes it begins to get distorted a little bit. If it just moves a little bit, grade 1. Moves enough, grade 2. And if it moves sufficiently that they're no longer engaged with one another, grade 3. And we do that. It's always that grade 1, grade 2, grade 3 that you hear so much of that are there. And maybe the classification has changed. Like I said, it's been 25 years since I worked at a hospital, since I wrote a medical journal. So I'm probably talking out of my anal orifice. You thought I was going to say a bad word. That would be me being a jack anal orifice, or an anal orifice hole. I wouldn't be that way. Try that. Tell somebody to do an anatomically impossible act with themselves or a farm animal of their choosing. You get the idea? It's easier that way, and the uneducated will look at you and go, huh? I told you to go blank yourself or the horse that brought you. Okay. What makes this unique? Here's the lateral ligament. Here's the capsule. In other words, it has a dense, irregular connective tissue enclosure and a dense, regular, as you can see, it extends from the zygomatic arch, sort of at the base of that condyle before it becomes the condyle itself, where it's still mostly on the wing of the bone, on the mandibular bone. It's just anterior to the acoustic meatus. All good. Here's what makes it unique. Bingo. It has an extra little piece, articular disc, just like a meniscus. Same material, fibrocartilage. That allows it that extra degree of freedom to slide side to side, to move back and forth, as well as, so that's an extra piece that provides an additional, what I would call a degree of freedom, or degrees of freedom of movement. Good news, bad news, more stuff to go over. The typical temporal mandibular joint dysfunctions are dysfunction of cartilage, and it's not as easy to deal with as a knee meniscus. I mean, if you have a torn meniscus, I have a torn meniscus. Okay, you go in there, grind down, you basically smooth down the edges, you suck them out arthroscopically. Deals with what's called scar cartilage. Most people, unless you're a high-end athlete, it's not going to affect them. Even professional athletes can have that done multiple times. The bad news about that is, after their playing career, they're going to have knee replacements, period. Guy who does do an analysis for everybody from ESPN and Fox since his playing days with the Redskins at the time, now the Washington Commanders, and the Denver Broncos, won 3 Super Bowls. Mark Schlereth. Okay. I mean, he had 21 knee surgeries, most of them for cartilage tears. And basically, it's, and I'm sure if he hasn't, he's going to have double knee replacements. That's the interesting thing. That's what makes the TMJ unique. And those things. So most common because of the shallow socket of the joint, even though that cartilage deepens it just like it does for the knee, almost always dislocates anteriorly. And so it's hard. I mean, it doesn't happen a lot. I've seen it happen in the knee. My wife tells me she's had that, but never so long, like with dental procedures. You know, you're having your mouth open for a long period of time, and they're manipulating it. She said sometimes it feels like you can't get back in, and it magically goes back in. I had a lady, this is an older lady who I just adored. I treated her when she was a regular patient, treated her when she was in a nursing home, knew her son, treated him, you know, an adult son who was probably older than I am. And she's in a chair like this, and I'm treating her feet. And all of a sudden, I said, okay, we're all done. And she's like, oh my God. And she started to cry. I said, what's up? I can't move my feet. It just jammed. Probably because the cartilage had more likely over the arthritis was so severe that little shards of cartilage had calcified and got trapped. And this is one of the problems with that. And she wasn't going to have any type of knee surgery. Thankfully, I said, just relax. I mean, I would have given her an injection of like a muscle relaxer or something. And I suspect I didn't have to. But maybe I'll ask she's an older lady. One of the ladies who were my assistants, stay with her, just calm her down, get her something to drink, whatever. And thankfully, it eased up. I can remember like it was yesterday. Oh my God. So dislocation. She's from Knox, PA. Anybody know where Knox, PA is? On Route 80, you see something called the Wolf's Den. It's a restaurant and a campground. Do you know where it is? Where are you from? Why do you know where Knox is?
Well, my dad's traveled all over the state.
Everywhere, yeah. One of those campgrounds that people spend the summer at the camp. You know, Christmas in July, Halloween, all those typical campgrounds. And it was at that time they had a really good restaurant. I don't know if it still is. Right, because you could see it right along 80. So almost always dislocates. It has to be manipulated back into place. All of these things, name it. And so usually it probably has more to do with people who have a chronic malocclusion. That's why we went through periods of time, I think, in dentistry where and I don't know if it's still the same, they were very concerned about bite and things like that. Bite plates. I have no idea what the state of the art is. I didn't have the problem, thankfully. Okay. The most freely moving joint you have, as you might have guessed, your shoulder. Glenohumeral joint. It's the old story. If you don't have stability, you have mobility. If you have stability, you limit mobility. So the hip is the exact opposite. It's all about stability, yet still it's classified as a ball and socket joint. The shoulder, the exact opposite of that. Large hemispherical head, very tiny cavity, and a relatively small labrum that just deepens it a little bit. So the golf ball and the tee is a wonderful analogy, bless you. Every so often you get golf tees that are the regular wooden tees. Sometimes you get the plastic tees that sit just a little bit more engagement. So for you golfers, I mean, you can see that. So the capsule enclosing is also very, very thin. That's there. So it's not particularly strong, particularly anteriorly. And that's why it tends to dislocate anterior inferiorly. What stabilizes it is you will come when we do the muscles unit next. Because there are 3 muscles in the back and 1 in the front. So 3 muscles that traverse the joint posteriorly and insert somewhere along the head of the humerus. And you'll come to know that their names, so I'll tell them to you now. And this is why you have to learn the anatomy about, you have the supraspinous fossa, the infraspinous fossa, because they're named supraspinatus and infraspinatus. And there's another one that's round, which is relatively small, but because it inserts in the head, it's called teres minor. Teres major is probably a more important back muscle, but it inserts on the shaft rather than on the head. So technically speaking, it has to go immediately behind the joint. And the subscapular fossa, because it kind of angles forward, if you remember the diagram, has subscapularis. That tendon also inserts, but anteriorly. So your stability is all superior with bone and posterior with muscle. You also have this, what they call a superstabilizer, the long head of the biceps, that helps to keep that in the joint as well. You have a lot of soft tissue structures. There's any number of bursal sacs. There's a lot of shoulder bursitis. Shoulders are very, very complicated. Okay, and they're just showing it to you here. So the labrum, fibrocartilaginous rim, just like you have in the hip. Yeah, you have a glenoidal labrum and an acetabular labrum. Again, still only holds about 1/3 of that head. So you still have 2/3 of the head out. That's why it's so easy to dislocate. I think that's optimistic. Okay, and then on the ligaments you have the coracoid process. That's where the short head of the biceps attach. Okay, you have from the glenoid to the humerus. Okay, but they're comparatively weak, and so that's where the anatomy points out why it goes there. There's any number of reasons. They're usually trauma. We used to see, again, in the emergency room, we used to see a whole lot of fights, and people would, like that. And I mean, you would get into fights, and there'd be a lot of trauma, and these would pop out. And in the emergency room, we would basically had to know what you were doing to put them back in. You have to know how to rotate it back in, or you can cause nerve damage. But basically, we would use intravenous Valium and relocate it, secure it with, usually with a sling, and basically observe the person until they were, be given the IV Valium, and off they would go. So you can see all of the structures. There's a bursal sac here. You have the subacromial, which is very famous and commonly inflamed, subscapular, and here you have the tendon sheath. All of that. There's a lot of soft tissue structures in and around it. It's very unusual. So they're giving you an idea. The labrum, here's the cavity itself. The labrum just widens that sort of circumference, and then you have the capsule, again, much more substantial here, posteriorly, and the bone helps you superiorly. So that's what they talk about this being a super stabilizer through that intertubercular sulcus. So another structure you should remember, secures the humerus to the glenoid. Here are the 4. You're going to have to know those eventually. You might as well just start processing them now. The rotator cuff. That's what I mean by cartilage. Cartilage is white, glistening, perfect. When it's arthritic, you see pockmarked, you see thickened, you see irregular colors. All of those point to the fact that there's in arthritis really, the hallmark of it is you start to see deterioration. Sometimes it's very, very soft, sometimes it's very, very hard. It just depends on the kind of arthritis. And what we deal with after this, really the functional, the physiological aspect is what goes wrong, and that's where we get into what we call the arthritides, the various types of arthritis. So we're going to cover a fair amount of them in this chapter. So mobility, structures weakest anteriorly and inferiorly, easily dislocates, the glenoid doesn't support it, arm tackles, falling, blows. You saw what happened with that with Xavier Worthy in that first football game we saw on the Monday night. And he ran, and here's this little guy runs into Travis Kelce, full speed. I mean, I love it. Kelce goes, I'm going to accept full responsibility. I am so happy he did that. You know, I thought it was my fault. It drives me crazy. Well, he's assumed full responsibility. I'm so proud. And I was so worried. I thought they were going to blame me for that. Who else are they going to blame? Stupidest thing of which I have ever heard. That's like not ending a sentence with a preposition. Winston Churchill, the stupidest thing of which I have ever heard. Rather than saying it's the dumbest thing I ever heard of. Yeah. Thank you. Look at all those muscles. So you can see this is pectoralis major. That's the deltoid. Here you can see the biceps, brachii and brachialis. Cover it. You can see the muscles as they look at it. So there's a lot of muscular support like that. The elbow. Make this the last one for now. Hold on one sec. Let me just get this, my kid. Yesterday. So the hinge joint, again, the trochlear notch of the ulna and the trochlea of the humerus, that's what they call them. The one you should remember is the trochlear surface of the humerus. Flexion and extension only because of the way it's constructed. Annular, A-N-U-L-A-R, means around. Okay, so and when you see, and there's a lot more than one annular ligament. That's the one that surrounds the head of the radius and keeps it in contact for pronation and supination with the radial notch. And then you have the ones you were so familiar with, the ulnar and lateral, or ulnar and radial. So you could, ulnar is medial, okay, anatomical position. Radial is lateral. Okay, so you could say medial and lateral. They're collateral ligaments. Every long bones, they always have collateral ligaments that are there. Here you can see it's really well organized. This is the acromion process. I beg your pardon. The olecranon process. This bursa is a fixed bursa. We always see it there between the insertion of the triceps tendon and the posterior aspect of the elbow and the acromion process. So that, and we will see bursitis in there. We did a lot of those. People had the bursa enlarged. They had developed like a tiny bone spur. When you take out the bursa and try to smooth off or chip off it and close it back up, that was the procedure was popular then. Don't know if it still is. So all those things. So it's a relatively well defined. But here is that annular ligament. Here's the radius. Here's the ulna. It sort of encircles it. Okay, not going over but from this portion of the ulna all the way around to the undersurface. And you can see this is, when you start seeing, this is a lateral collateral ligament. From epicondyle to the epicondyles or bony prominences there. You can see it looked at pretty, here's the medial one. So here's the ulnar collateral ligament. You can see it's not just a strip, multiple strips. And what they're using today, when that is damaged or torn, a la Tommy John surgery, they'd graft from another spot do an autograft. Nowadays, they're using more of drilling holes and putting in, I'm trying to describe it. Again, it's almost like an elastic band that is designed, just like to hold that, so inherently it's more dynamic. And that's been a very successful procedure. And you can see all the pros, they all go to the same people, that Neil Eritrich in California, and with the foot, they go down to the guy in Georgia to do those things. So, I mean, they're there for, it's like the Steelers going over, if you didn't know, it's over at St. Margaret's, that Burke and somebody, orthopedic group I'll look up, they're really good with sports. And I think that's everything for today. We'll start with the hip. On Friday, and again, bad news. I made a mistake. Our exam is on Wednesday. I will not be here that Friday, on the 5th. I know. I know. You'll get over it. Don't, no tears.
I thought it was on Monday.
Our test is, right. Monday, my other class has the exam on Wednesday. The Monday, we're doing that. I won't be here on that Friday. You'll get your exam results by Friday.
So, for the lab exam,
Yes.
like, you know how this has like the bone and then like the stuff in the bone?
Mm-hmm.
Is it gonna be like